all amazing lessons. This one comes from country music. But I added a lyric to carry. I can't carry a tune. But that is how far we have left to go. The field of pediatric cardiac surgery, as we learned this morning, is only about 63 years old. In 1954, C. Walton Lillehei, he's from Minnesota, where all the women are strong, the men are good looking, and the children are above average, and that's where I'm from. He performed the first successful open heart surgery on an 11-year-old boy with a VSD, using the boy's father as bypass. So 30-something years ago, neonates with ductal-dependent single ventricle congenital heart disease had no options. They had no options until we developed prostaglandins. And the initial trials for prostaglandins were not until the late 1970s. So the first stage 1 Norwood for a neonate with hypoplastic left heart syndrome was approximately 1983, depending upon which reference you read. The field of neonatal and critical congenital heart disease surgery for complex single ventricle diagnoses like hypoplastic left heart syndrome is just over 30 years old. Prenatal diagnosis did not become feasible until the mid-1990s, and it's really only until recently that it's become standard of care. So in 2017, it's possible to know by 14 weeks gestation if you are carrying a fetus with hypoplastic left heart syndrome. Over the past 30 years, there's been and continues to be remarkable progress in all of these fields, all resulting in significant improvements in survival for newborns born with complex congenital heart disease. Lesson. All of these innovations have made us expect survival. All of our drive, our determination, our dedication, our diligence, the resilience and grit of our patients and families, the teams that we work with, and the innovations like the innovations we've heard about today have all made this evolution for the care of single ventricle congenital heart disease and hypoplastic left heart syndrome possible. But the book is not finished. The story is still being written. There are many chapters to go. We now have expectations and a set of single ventricle truths. What do we know to be truth? We know that prenatal diagnosis is now the rule, not the exception. We know that because of parents, critical congenital heart disease pulse ox screening programs exist in most states in the United States that can pick up those babies who weren't diagnosed in utero. We know that for hypoplastic left heart syndrome and other single ventricle defects, there are 3-stage surgeries that occur in the first 4 years of life. We know that the first stage, that there are now 3 iterations for that, including the stage 1 with the VT shunt, the stage 1 with a sono or an RV to PN conduit modification, or a hybrid procedure. We expect survival. We can pat ourselves on the back because we have done an amazing job. So what are the truths in 2017? Innovative, stunning, remarkable progress has been achieved. Survival to adulthood is expected, and the numbers of those patients continue to grow. There are multiple centers here in the United States and across the world that expertly care for these patients. Our survivors graduate from high school, they go to college, they need birth control. They get married, they become pregnant, they are living their lives. But they are survivors who will require lifelong care that will include adult healthcare providers. Many of our patients are doing well in childhood, but there can be issues in adulthood. There are new and trending tweets or discussions in the single ventricle world. We're obsessed, and we should be, with what's going on with the Fontan liver. We are captivated by the newly discovered, very old lymphatic system. We can rescue the failing Fontan with VADs and ECMO and takedown and transplant. But we question if it's the right thing to do for every patient. We now seem to categorize our Fontan patients into two groups: failing Fontans, with all of the things that we're afraid of, and well Fontans. But we spend all of our time and energy with failing Fontans. And so when we define well Fontans, they're just all the others who aren't failing. But what about that group? How should we be caring for that group? How should we survey that group? Should we survey and screen this group? And if so, how and what are we screening for? Fourth lesson, not everyone thinks we should do this. Because everything's fine. The patient's well. After years of living from surgery to surgery and in fear, life is finally normal. Leave them alone. Why should we look for problems we can do nothing about? Patients and families are stressed enough, and I agree. This will only increase patient and family anxiety. You're just doing this for research, not actual clinical care. There will be, and it's true, a cost and a financial burden to surveillance. And if all will eventually fail, we should just leave them alone until that time. I don't need any help managing my Fontan patients. I can do anything you can do. Why should we survey and screen all Fontans, even well Fontans? The pathway to the Fontan in 2017 is scrutinized, scripted, staged, recorded in databases, recorded in iPads. There are interdisciplinary teams, there are neurodevelopmental evaluations and neurodevelopmental teams. There is an intense surveillance of these patients up to the Fontan. We know every cough, every hiccup, every diaper, every ounce. But what happens after the Fontan? The road is less traveled. There's no defined or agreed upon routines, there are no stages, there's no script, there's no team of specialists waiting to take care of these patients. And when it's least expected and without warning, even in our well Fontans, we can run into major potholes that completely derail quality of life. There can be significant challenges for these patients. And there are other issues and questions. Leg pains are chronic. There are migraines within the group. Puberty can be delayed. There's hepatomegaly. What should we do about that? What should we do about birth control? This is an anxious group of adolescents and young adults. Who should we refer these questions to? Does the other specialist even know what a Fontan is? Because that road's less traveled. There's no team of specialists. There's no directions. There's no Starbucks. There's no gas station. The road isn't even paved. And when we refer to these specialists, they don't see the elephant in the room. They just look at their own specialty. Lesson 6. And this has been a very bitter pill for me to swallow. This is not normal physiology, ever. Blood is routed to the lungs. It's not pumped there. There is elevation in systemic and central venous pressure. There's an impact on ventricular filling and function. The liver, because of this elevation in pressure, is congested with elevated hepatic venous pressure. The liver, the major producer of lymph, goes into overdrive, producing lymph. And there's impedance to the flow of lymph because it's coming back to the heart on the Glenn-Fontan side of the body. It's not fixed. It's not repaired. It's not corrected. Dr. Fontan never envisioned that it was an anatomical correction. It was the routing of blue blood to the lungs. Initially, we see mortality during those first 2 to 3 years of life with surgery. And then, for most patients, there is a period of wellness. But in the second decade of life, and then in the third decade of life, we begin to see increasing morbidity and mortality. there is an impact and burden over time to our patient and to their families. There are emerging Fontan truths. Survivors, even those who are well, are an at-risk group. This physiology is not normal. It impacts multiple other organ systems, both acutely and over time. And the mechanisms behind complications like plastic bronchitis and PLE have not been well understood, and we referred them to pulmonary and GI until we owned them and followed enough patients to be able to determine and prove that these are lymphatic system derangements. Risks cannot be screened for by simply an echo, exercise testing, ECG, and a Holter, because it's not just the heart that's impacted. We now measure time and age in this group by years out from the Fontan, and the risk for comorbidities increases with time out from the Fontan. What are the truths in 2017? This is a health condition that is persistent and long-lasting in nature. This is a disease that lasts longer than 3 months. It may slowly get worse over time. It may lead to mortality. It may cause permanent changes to the body. It may impact quality of life. And this is the World Health Organization definition of a chronic illness. When you have single ventricular congenital heart disease and you are a Fontan, you have a chronic illness. And the mandate for chronic illness care is that we coordinate their care in a medical home and in a multidisciplinary fashion. Next lesson. We have an opportunity to create this for our Fontan patients. The road less traveled needs company, it needs rest stops, it needs a good bus driver, it needs a team of specialists who know what a Fontan is. In 2011, we created the Single Ventricle Survivorship Program at Children's Hospital of Philadelphia. Initially, the program was created to care for patients who were not well, that group of failing Fontans. But what quickly happened is that we became a program that follows failing and well Fontans. This is a multidisciplinary program that includes cardiology, a liver doctor, an endocrinologist, an immunologist, and we have other providers in other specialties if we need them. Our mission is to survey all survivors in a multidisciplinary fashion, to evaluate and manage those complications, to coordinate additional specialty services and programs, to educate our patients and families about the Fontan, the future, the liver, exercise, healthy self-care, and avoidance of risky behaviors, to facilitate transition to adult care, to coordinate transplant evaluation if we have to, and to determine the most appropriate and cost-effective testing protocols, the timing for those testing, and the intervals for follow-up for patients. We want to identify at-risk patients before symptoms so that we can intervene early. The clinic is for specialists. Patients go into a room, the specialists are rotated to the patient. We have a coordinator or a cruise director so that we all know where to go. Testing has occurred either the day before or a few months before, so that in clinic we have results. We meet to discuss your child before we see your child, and we meet after the clinic to discuss your child again. This is some of the testing that is performed for multidisciplinary clinic. Again, that testing is coordinated before the clinic day so that we have results. Our patients come from the Children's Hospital of Philadelphia, but about a quarter of them are patients that had surgery with us in the past but are followed elsewhere in the country who come back to the program. We don't care where you had your Fontan. All patients who have had a Fontan are welcome to participate in the program. When we looked at our data from 2011 in January to the end of June 2016, over 356 patients were evaluated as new patients. The median age was 11 that we were first seeing them in clinic. The reason for evaluation, all of those things that are scary to talk about, but what I want to point out is that 60% of the patients we saw and we see in this clinic are well Fontans. Most patients in our program are well. What have we learned? Most of the patients in our program have had an extracardiac Fontan. In Philadelphia, we love the fenestration, and so 3/4 of our patients have had a fenestrated Fontan. The oxygen saturation, whether or not you have a fenestration or not, you all end up with the same saturation, it seems, in the teenage years, which is the low 90s. Only 40 of our patients, 11%, have had to have a pacemaker, and there has been mortality in the group. We are a center for hypoplastic left heart syndrome from Dr. Norwood's era and continue to be, and so the bulk of our patients are patients with hypoplastic left heart syndrome. Aspirin is our favorite choice for anticoagulation. Only 11% were on warfarin. We like ACE inhibition, despite evidence which indicates we should maybe question that. We use Lasix. 20% of our patients in this program were on sildenafil. And we like to use aldosterone as well. We do abdominal ultrasounds as part of the testing for this. Specifically, we're looking at the liver. About over half of the liver ultrasounds have been normal with no findings. But the other half, there have been findings. About 5% have had gallstones. They're asymptomatic with this. And we have made some kidney diagnoses as well. Single kidneys, polycystic kidney disease, etc. We check a CBC with diff, the absolute lymphocyte count. We suspect that the Fontan creates lymphatic derangements in all Fontans, but the subset of patients get actual protein-losing enteropathy. But we see in all of our patients a somewhat lower absolute lymphocyte count, so there is some lymphocyte loss going on, and this increases with time out from the Fontan. The platelet count begins to fall the further you're out from the Fontan, likely related to liver. We see a lot of warts and molluscum, especially in PLE patients, but across the board. Interestingly, despite the lower lymphocyte counts and the warts and molluscum, it overall is a very well group. We don't get sick a lot. The lymphopenia worsens over time after the Fontan. We look at multiple growth factors, both lab and DEXA scans and heights and weights. This is a group that doesn't seem to reach their full genetic potential for height. This is a group in whom their DEXA scans can be abnormal as well. So bone mineralization can be impacted. We called out that the liver is a problem for our Fontan patients, and in 2012, we recommended a liver biopsy and a cardiac cath in all of our Fontan patients when they were 10 years out from the Fontan. Not age 10, but over 10 years out from the Fontan. And we've recently published our findings. 67 liver biopsies in asymptomatic children and adolescents. 100% of the biopsies showed some degree of liver scarring. But the only risk factor we could determine with just 67 patients was time out from the Fontan. This is not normal physiology. There can be repercussions to multiple organ systems, including the lymphatics. Some of our patients clearly have what we've coined the Fontan circulatory syndrome, where there's been an impact on their lymphatics, on GI inflammation, on their kidney, on their bone mineralization, and on their liver. Lesson 8. We're faced with an iceberg here, and icebergs are beautiful. We can run into it and sink the ship. But there are tips for avoiding icebergs. We can be proactive and screen. We can confront the challenges with the same drive and determination that we confronted single ventricle congenital heart disease 30 years ago. We can be innovative. We can find a way over or around those obstacles. We stand on the shoulders of giants. Our history has always been and continues to be about hope. The Fontan impacts multiple other organ systems. It's not a normal physiology. This is a chronic illness. Many, actually, most of our patients in childhood are well, but this, for some patients, could change with time. Multidisciplinary screening of Fontan survivors can identify problems early and allow for early intervention. We cannot recognize trends, understand these complications, or characterize what wellness looks like in our patients until we begin to care for and follow these patients as a cohort with a dedicated team of specialists. We need breadth, depth, and context with cat-like vigilance and masterful non-intervention. This program has created opportunities. We can make the Fontan the best it can be for each patient. We can optimize the tolerance of this physiology well past 30 years of age. We can identify complications early. We can be creative and innovative and proactive and cost-effective. And we can use this as an opportunity to promote a wellness lifestyle. We can encourage healthy diets and intentional physical activity. Our endocrinologist just yesterday in a multidisciplinary clinic told every single patient to bounce up and down, jump up and down 30 times every morning when you get out of bed, because there's compelling evidence that that is good for all of us to do. So I did 10 jumping jacks when I got out of bed this morning because it's good for our bones. We can assist patients to embrace their health potential and their self-care. We can conduct research. We can improve the scope of our screening. And what all of this has led to in Philadelphia is that we are about to embark on what we are calling the Forward Project. Fontan Rehabilitation, Wellness, Activity, and Resilience Development Project. So that we're going to look at exercise and personal trainers. There is compelling evidence that we have done our patients no favors whatsoever by restricting them from gym and physical activity. If you run, if you build muscles in your legs and you are running, then what are those muscles doing? They are contracting. And what does that just look like? That's a pump. That helps pump blood through the Fontan. So if you're the parent of a single ventricle patient who's a Fontan out there, get them on the treadmill. Get them walking. Make sure they have good shoes. All right. Get them active. Aerobic activity, building good muscle strength in your legs is important. If I could hire a personal trainer to meet you 10 days after the Fontan, I would, to work with you the rest of your life. Mental health. We're scratching the surface here and we need to do a better job because our teenagers are anxious. And sometimes that gets diagnosed as depression, but there is anxiety. Of course there's anxiety. Who wants to live through adolescence ever again? What an anxious time of life. And you compound that with a chronic illness and the fact there's something about you that's different when the whole goal of adolescence is to be like everybody else. But this, when you take your shirt off, reminds you that you're not like everybody else. How do we help our patients deal with that? What should good nutrition look like? Because some of the patients that are coming to my program are actually malnourished, and it's because their parents have put them on a low-fat diet. And you have our endocrinologist and our liver doctor saying, feed the child. Okay? Education, both for us, for our colleagues, but also for our patients and for our families. We have taken heat for using that word survival because some people have felt that this word survival has a negative connotation. But the word survive means to remain alive, live, sustain oneself, pull through, get through, hold on, make it, and keep body and soul together. And that's exactly what our single ventricle patients have achieved. Survival. It implies wellness, opportunity, hope, and a future. What is the lesson and role of the survivorship program? I need to make sure that she's well balanced on that wall and help her not fall off. But if she does fall off, then we will catch her. This involves a huge team of people at the Children's Hospital of Philadelphia. I am blessed and grateful to be a small part of the effort. Thank you very much. Now, every jumping jacks, 10 of them.
And now we have Jean Connor. So there is information in your bags from CHOP if you want more information about the single ventricle program. It's in there. So, and they also have a cool pen. Yeah. So I
Hello? Yeah. Okay. Well, I am so excited to have had Katie present, because so much about what I'm going to talk about is just nursing. And I know that all of you have had the experience of having a nurse if your child has had heart surgery. But this really is a journey about nursing, and how along the way of this journey, actually Mended Little Hearts became an important partner. So with that, I have no conflicts to disclose. And hold on, my screen over here. This way. So sorry. Okay, here we go. All right, so what I would like to do is really talk to you about the rationale for undertaking this, because I think it's important for us to understand why it is we're actually doing things, and really making sure there's a relevancy, because whatever we want to do, we want it to be a sustainable idea. And I really wanted to then talk to you about evidence and what does that mean, not only for our profession, but how it impacts our population of patients that we take care of in cardiovascular nursing. And then really talk about partnership, and it's a partnership that has begun. I'm trying to think, Jody, when we met, but it's at least 6 or 7 years now, right? And that happened the first moment I think I said hello to you, I became an instant, fan of Mended Little Hearts. And then talk about this experience that we've had in this consortium, and I'll tell you what C4MMP stands for in a second. And then really describe strategies for utilizing this consortium to generate knowledge and network. So I wanted to just start with who is the pediatric cardiovascular nurse of today, because I think that's an important thing for you all to understand. I think you just saw probably one of the best examples of being altruistic. Katie, thank you for that. That was tremendous. I know you said you play a small part, but really I think so much of the energy of that that effort is really led by you, so thank you. But so that's an example of being very altruistic. And then as nurses, we are looking for that intellectual challenge. We don't show up to work to be bored, right? We show up to be challenged, and I think that's something that you should understand. And that we always have, probably our most important thing is real passion for caring for patients, staff, and society. And I think it's important for us as a pediatric nurse to understand is that it's not just about the patient, it's about the family too. And I think that's a really unique part of being a pediatric nurse. But we have a number of challenges, and it's not like these challenges go away. So I think you as patients and families should understand from our lens what those challenges look like. And really this idea that there is an overwhelming increase in the complexity of care. As a nurse, And I'll start when I was a nursling, so I'm dating myself. But 30 years ago, the patients that I took care of at the bedside definitely don't look like the patients at the bedside today. And even if you looked 5 years ago, how much that has changed. So talk about that intellectual challenge. We get that opportunity every day. Something that's also really has become very much part of the professional role of nursing is how we respond to the increasing regulatory burdens. This may not be something that's so visible to you, but and this is a good thing though, right? So it ensures that there's a certain level of quality to really impact the outcomes of our patients and families. But at the same time, we have to respond to that, and we have to be able to articulate how we maintain those regulatory requirements while we're providing care. Now, not everywhere, but there are some pockets of what we would characterize an unhealthy work environment. And again, that's an opportunity. Nurses also have a certain degree of moral distress. It is very challenging. Even though we show up, we have a heart too. And so to not have an emotional impact on what we're doing as part of our work, I wouldn't be telling you the truth. And interesting to nursing, really right down to the bedside, we all are conscious of this need to be not only effective, but also efficient. Reality is we're all living in a resource-constrained environment. But as a profession, how do we respond? And I think this is so important for you all to know, is through this idea of courageous care. And it's having the courage to ask full questions and to inquire about best practices. And so that's something that is always really part of nursing, that you have to have the courage to care. And, I think something else that really maybe is more obvious today than it was even, let's say, 10, 15 years ago. Nursing is actually a profession. So physicians have always portrayed themselves as a profession, right? Well, nursing always wasn't portrayed as that. Actually, nursing started out as some would consider prostitutes or servants. So we have come a long way, that now it really is well established that nursing actually is a professional discipline. And there is a certain responsibility when you are considered a professional. You are accountable to actually developing knowledge. You're accountable to disseminating knowledge. And most important, as a professional, you're accountable to actually utilizing the knowledge. And so when I think about our profession, we're accountable in many different ways. We're accountable as a professional, and those three ideas I just shared with you, to our peers, to the regulatory policy bodies, to our interprofessional healthcare team. So as a nurse on an interprofessional team, we also have to make sure our voice is present. Accountable to our patients and families. And so that is probably one of the most important areas that we are accountable. So this idea of the Consortium for Congenital Cardiac Care, Measurement of Nursing Practice, or C4, is this whole idea of how do we accomplish that ability to be accountable. It was apparent to me when I started thinking about this idea and talking with my nursing colleagues across the country, that as nurses, as pediatric cardiovascular nurses, so you could talk about nursing in general, and you could talk about pediatric nursing, but when you really kind of go to that, that third level, pediatric cardiovascular nursing, how is it that we articulate our voice? What's important about a pediatric cardiovascular nurse is that they tend to be spread out. So even though congenital heart disease is the most common congenital defect of all the different defects one can be born with, it's still relatively rare. And we're in a time now where it's amazing that there are actually a number of congenital heart centers across the country. Probably all of you go to a rather large center to get this very expertise care. But when you think about us in each of these centers, we're kind of spread out, right? And so our voice may not be heard as much. So this idea of coming together through this consortium was a way to really bring all of those voices together and to really think about our profession together. And this is actually our webpage, which is something that each of you can go on and look at what we're all about. We started this activity probably in 2011, and just 6 months ago actually got a webpage. So we have been a group busy on a lot of different things, and now are finally putting ourselves forward so that all can hear the voice, and not just through me and a select other few. But the whole reason that we came together was this particular aim, was to really identify and test measures of quality nursing care, right? So you as a patient and family, you can probably think of nurses that really gave your child or really took care of you just so well, right? That's quality nursing care. But how does a nurse articulate that, right? I just told you we now have environments that we have to not only be effective, we have to be efficient, meaning we have to justify, we have to validate why is it that you need a specialized nurse to take care of a child that's had congenital heart surgery, right? We actually have to tell that story. So we do that through measurement, right? And so what I thought was important is that we really don't have pediatric cardiovascular nursing measures that can tell how that high quality of nursing care, what that looks like. So we came together, and when I say we, I'll tell that a little bit, but currently today, we are a collection of 32 pediatric cardiovascular nursing programs. Now, there are definitely more programs in the country. It's not just 32, thank goodness, right? But I would say to you, each week or each month, I have somebody, because now it's just word of mouth. So if you don't know if your pediatric cardiovascular program participates in this, please tell them to go and look at the website, and please tell them to send me an email, because there's no cost to this, and this is another nice thing, considering we live in that resource-constrained environment. And here's the team. Now, I will tell you, there I am, along with my partner, Dr. Patricia Hickey. We are not sisters, although we may look like sisters. Interesting, the two other kind of lead support people, when we had to take pictures, they showed up like with the same colored shirt. They're not sisters either, but we kind of all have this similar look. But there's really four like main people that lead this out of Boston, but it really is, I have to say, quite a big village. So thinking about Houston, how it's kind of that medical city, this is kind of that virtual medical city of pediatric cardiovascular nurses. And I have to say, it's a pretty strong city, and it's a very dynamic city. And I can't tell you how all of those things that I said, that what our nurses, that's what this group is, because when we come together, and we come together through monthly conference calls or sometimes other forums, the conversation is so exciting, it's so passionate, and it's about how can we be better. Now, how did we start? Well, the first thing I had to prove to myself, because I'm just always so conservative and nervous, right? What is my job? My job is actually a director of nursing research at Boston Children's Hospital in their cardiovascular and critical care areas. And so just by nature, I tend to be a little bit of a scaredy cat. And I had to prove to myself that we really needed something like this. We really needed a forum. And so the first step was really just reaching out to nurse leaders across the country of these cardiovascular programs and really start talking to them. And I did this in a very formal way because I'm a researcher. And in a very formal way, I interviewed them and really started talking to them about, well, how do you define quality nursing care? How do you measure it? What does it look like in your program, given that you are a high volume program? You are having amazing outcomes. And we know those patient outcomes are not by accident. And we know that there is a nursing contribution. But interestingly, and I interviewed 20 different programs just because I got to the point that I wasn't hearing anything new, because the message was similar in all these programs. We actually do very little nursing measurement, and specifically cardiovascular nursing measurement. And I said, well, goodness, that sounds like an opportunity, right? And so it was from that point on, and then as I was finishing the interview, I said, well, you know, I had this idea that I actually want to bring together this forum. And I said, and it's going to be a nurse-led forum. And I said, and we're going to invite people along the way, but nursing really needs to be a central voice. And I said, would you like your program to participate? And everybody that I asked said yes. So that's what kind of kicked us off. And our first step was really coming together, all understanding what the main aim was, and really breaking up into working groups, because these nurse leaders also offered me what they believed were priority areas that nursing was central to and that nursing should be measured by. And there were priority areas around nutrition, around preventing pressure ulcers that can occur on the skin from being still when you're recovering in the ICU. They wanted me to think about our work environments. These environments that we take care of you all are high stress environments, right? And the stress not comes from only taking care of that very sick child and their family, but it's also other things that could involve around the team. Okay, they wanted me to think about that. How would we measure that? They felt very strongly we needed to figure out how to measure the nursing contribution around clinical deterioration, knowing that that nurse is that last, but also that first line of defense. What was our contribution? How nurses manage pain? How can we measure that? How do we do that well? Patient and family-centered care. I think one of the things that nurses get to do is really spend time with the patient and family at the bedside. And really taking on this whole idea of the adult with congenital heart disease. Think about this. We are trained as pediatric nurses, but we actually, as a pediatric cardiovascular nurse, we take care of patients and families across the care continuum, across the life continuum. We meet families often birth, right? We talk about prenatal diagnosis. That's when we first start those relationships. So, but we also take care of the adult that's now, as Katie said, right, those first successful surgeries were 63 years ago. Well, guess what? We have 63-year-olds in our unit as well, right? So we have to learn, how do we, as pediatric cardiovascular nurses, all make sure that we're also giving high quality care for our adults with congenital heart disease? So these were the areas that we first set out. Now, there are different ways that we characterize measurement, whether it's something's called a structure measurement, a process measurement, an outcome measurement. But this was important, for, again, for how we articulate quality nursing care. So just as far as the process that we used something called the National Quality Forum, which is that highest level of measurement, development, and evaluation. And that we started out with our different topic areas, and as a group developed 28 measures. We then, through this evaluation, this rigorous evaluation, narrowed down from 28 to 10 as a first set of measures. And here are the measures that we came up with. We had a measure specifically on the health of the work environment, but here are the things that all of you are actually pretty sophisticated about. We decided it was important to measure the years of nursing experience. Now, let me ask you as a group, when your nurse came into the room, was that one of the first things you were thinking of, how experienced she was? Well, maybe you're not thinking that just a moment, but when we asked you in a very formal way, you had a thought about that. Something that we also thought was important to ensuring that there was a quality nursing care was how educated, right? How was that nurse prepared? So having a bachelor's education. There's something else that we've been able to empirically prove that having a specific nursing certification in critical care or pediatric critical care, that's a pretty important thing to ensure that you will have a nurse that can give quality care. But we also know there are things that may impact things like nursing staff turnover. Clinical measures that we came up with was things around nutrition. I said that that was a priority area, so things like weight gain, feeding safety. Clinical deterioration would be utilization of early warning scores to try to prevent that. And about our pain and preventing pressure ulcers. So these were the 10 measures. Now, when we went through this evaluation process, not only was it important, and this is where the partnership comes in with all of you, it was not only important to internally validate these measures and make sure that there was agreement amongst the group that these were the right measures, it was important to externally vet these. And so when I was thinking about this, yes, we asked formal groups like the American College of Cardiology, their pediatric section, the American Heart Association, there was a nursing expert group. There was the Society of Pediatric Nurses. At Boston Children's Hospital, we have a nursing quality measurement committee. So all of these groups vetted these 10 measures. But I also thought, well, when we go back to that accountability slide, who else are we accountable to? Our patients and families. And so with that in mind, because this was a national collaborative, I reached out to Jody and I said, we've started this work, and I said, and I really want to carry this thought fully through. I wonder if you would be interested serving as an external vet at Mended Little Hearts and participate in this exercise. Well, I, as the leader of this effort, present each of the measures to a group of your families, talk about the measures, and then have them go in, just like we had these other groups, through a very formal way and evaluate which measures they thought were important and a real prioritization of that. And so interestingly, so we were able to do that. So Jody said, yes, that sounded like a great idea, as you can imagine Jody saying, right? And she immediately put the word out, and we actually had a great group of parents, and I don't know if anybody's in the audience here, but we had parents that had young children, as well as parents that really had teenagers, young adults. We actually had, I think, at least one or two adults with congenital heart disease, so they themselves were able to participate. And so going through this process of just even presenting the measures to the groups, and we did this via phone calls, so through a series of phone calls. And then I had them, in a very formal way, sent them an electronic link where they went into this database and answered questions. And here's the thing that was shocking to me. It almost mirrored exactly what our professional colleagues thought. So probably, and this is a figure showing you the way people weighted each of the measures. And if you look where it says nursing experience, 40, the patients and the parents from Mended Little Hearts actually thought that was the most important thing. And interestingly, that is what the nurses thought, that's what the physicians thought. So everybody's seeing the same thing. Well, we know, if we all know nursing experience is important, and actually Dr. Patricia Hickey, who was in the photo with me, and I have done work, and we have shown in a very scientific way how nursing experience impacts the mortality or death, right? So higher experienced nurse, lower risk for death. We've also shown that in a patient having complications after the heart surgery. Higher experience, lower risk of complications. We've also shown that in education, higher educated nurse, less death, less complications. Our most recent work, and this is actually, we've submitted this for publication, so you're hearing this hot off the press. We have shown this through the research that certification, nursing certification, less complications. So it's important, right, when you think about who is taking care of your child, that these different characteristics, right, these descriptions actually can impact the quality of the nursing care you receive. But it was interesting to me that when we had the ranking, the Mended Little Hearts actually ranked very similar. So you as the observer, the consumer of care, you actually have a very accurate assessment. Now, I'd just like to end with a couple of slides showing you that we actually took these measurements out on the road and we went through this whole process of what we call benchmarking. Now, again, this is hot off the press. Hasn't been shown anywhere before, so you're actually the first ones to see it. But we were able to, with a subset of pediatric cardiovascular programs, ask nurses to go and collect this information. And so let's see how we do. We're going to measure this. What do we look like as a community? Now, this is a collection of 9 sites, right? So we took these 10 measures and we had 9 sites actually go collect the information. So the red line, anything below the red line is good. Now, we were able to determine in our research that if you had in your whole nursing staffing model, 20% or less than, so less than 20% of your nurses were 0 to 2 years, okay? Then that resulted in lower mortality for your whole entire unit. Okay, so when we looked at the whole staffing model, we looked at the proportion of nurses. If you had 20% or less of your nurses that had that 0 to 2 years, then your unit was noted to have less risk for death. Now you can see there's opportunity, but a number of these units were less than that 20% mark, right? So this is good. In the next one, we looked at the education. And this is where we really excel. Dr. Hickey and I have looked at this in a couple serial surveys, the education of our nurses. The Institute of Medicine has put forward really a charge that by the year 2020, 80% or more of nurses should be BSN prepared, right? Bachelor's prepared. Now you can see already, and we're not there, but it seems like it's right around the corner, that all of the centers were either almost or really above that line, right? So very good. And I have to tell you, still in nursing today, the most common degree is an associate's degree. So this is a very highly specialized and sophisticated group of nurses that are taking care of your children. The other thing that I just wanted you to show is this whole idea of certification, because I said this is really new research that we are just now disseminating. And that we were able to also have a cut point of that 25% or more in your staffing model if they were certified. And you can see in many of these, only one program, then they were almost there, were below that mark. So what's the message? The message is that you actually have in these different, very highly specialized programs, nurses that have a lot of experience, that are very much educated, and really believe certification is a hallmark of expertise, and go and get that certification. So just to close, and we have other data that we're really excited about, but some of the other opportunities we identified in this consortium, that it was not only important for us to be able to measure ourselves, we really thought, you hear so much that there's so much variation in healthcare. Well, we didn't want to limit ourselves in that thinking. How much variation is there in nursing care? Or certain types of specialized care that nurses often provide at the bedside? And so there are a number of different, what we call states of nursing practice that we've been able to establish. And if you go on our website, you can see these are some of the topics that are really hard, challenging ideas. But coming together through this forum, we've been able to say, well, what are you doing? What are you doing? What are you doing? And this has been very helpful to us. And, often when you think about survey methodology, response rates tend to be low. Well, just to give you an idea, the average response rate is around 20%. In these different surveys that we've been able to conduct and really establish and generate a report, the response rate's over 80%. So that's great. So you really have a sense that you're getting that true story. And we're also carrying out as a group some very scientific types of assessments. And so these are just, again, another opportunity for us to not only advance our practice of measurement, but actually the science of nursing. So for the next steps, we're going to continue to grow. We believe that this is a sustainable idea. Like I said, we've been together since 2011, and we're now 32 sites. And we believe that this is that kind of stronger together idea. We're really starting to very quickly generate things that nobody really understood. And we're able to now really link these to patient outcomes. So we're finding our way to articulate ourselves, right? We know how to say, yes, we are providing quality care and what that takes. And that's important not only for you as patient and families to understand, but it's also information that's important for us as nurses to be able to say to our leadership, there is a reason why we need to have retain a certain years of experience of our nurses, okay? That costs money, but we believe it's worth it because we believe it directly impacts, well, we know now it directly impacts patient outcomes. And I think that as we look forward, we really need to benchmark ourselves. Just as I think one of the earlier sessions, we were talking about transparency, we need to be just as transparent as everybody else on the healthcare team. So with that, I would like to end with, it was amazing to me when the plane was flying in. I was looking for all the water. Interesting, I didn't see a lot of water, at least the part that I was flying over, but I would say that it is incredible, the resiliency that we have seen of late in Houston, in Florida. And it really is the story that I think you understand resiliency so well. But again, also our frontline responders. And so again, I think that in recognition of Houston and really going through and hosting this for us, even though they've had this incredible challenge, it really is that frontline staff and the courageous care that you're seeing in action. So thank you very much.
So Dr. Sood has very generously agreed to go after lunch. I know you guys are hungry. Emily got us a great lunch today. She's just been wonderful. She's also outside with the Dash tickets. She's at registration, so you guys can pick them up, what the number you want. And then we are going to continue at 1:30.
If any of the presenters are here for the rest of the day, if you could come up here and speak with me briefly.